Hello, everyone. Good morning. And big day has finally arrived, and we are going to do some quick recalls. That this is going to be one of the grand recall. Okay, so here we are going to see some important things. So we can't cover the whole lot. So we'll try to cover maximum. And here I am, Dr. Rohini, and you are watching an academy learning platform. The the various educators are going to definitely train you the last minute with last minute questions. And here we are going to do some anatomy here. And the first one, let's see, before I give more introduction about myself and other things, now that you are in a mood to start with the studies right away, let's go ahead with some of the topics. Right, so here it is. Let me just make sure that everyone is in and right. Okay, there we are. All right. So here is lumbar puncture type, epidural anesthesia. So here when lumbar puncture is performed, the needle is entering the subarachnoid space. So remember, it is entering the subarachnoid space. You know that the spinal cord ends at the level of L1, and usually the needle is inserted between L3, L4 or L4, L5. The reason being the spinal cord ends at the level of L1 and there is no danger to, damage the spinal cord. So that doesn't arise. Then remember this number, and then you also remember, but in case of, in adults and it does not end at L3 in young children, a dural sac extends caudally up to the level of S2. So remember, dural sac is up to the S2 and spinal cord ends at the level of L1 or L2. So remember these two key things. All right. Next, before the procedure, what do you do with the patient? You should be examining for signs of increased intracranial pressure. That is one thing you need to keep in mind. Because of the cerebellar tonsillars, sometimes they may herniate through the foramen magnum. So that also chances are there. So you need to keep in mind the cerebellar tonsils are not herniated through, and intracranial pressure is also maintained well. Only after you watch for all these signs and symptoms, only then you can administer the epidural anesthesia or lumbar tap you can do. So this is the lumbar spinal puncture, and here you can see it ends at the level of this L2, and this is at the level of L2 or L1, and then here you can see the filum terminale. Filum terminale is nothing but the innermost covering, that is pia mater, and you can also see the coverings around the body of the spinal cord, the lamina of the spinal cord. You can see ligamentum flava. You can see the anterior and posterior longitudinal ligament. Do you remember the posterior longitudinal ligament? Longitudinal ligament extends upwards as what? It extends upwards as the membrana tectoria. Okay, so keep this in mind. Then there is all these other structures. The end of dural sac also you can see here, that is at the level of S2. Okay, dural sac ends at S2. The filum terminale is nothing but the pia mater. So keep all this in mind. Next we'll go to the herniated IV disc. Herniated IV disc, it is this one, herniation of the nucleus pulposus. This is nucleus pulposus, and annulus fibrosus is the outermost one. Nucleus pulposus is actually the remnant of the neural tube. You have to remember, it is derivative of neural tube. So keep that in mind. And here you can see the posterior longitudinal ligament. Okay, that's what I was talking about. It extends upwards as membrana tectorium. Okay, this is anterior longitudinal ligament. Okay, this is what actually, damages, and you can see in the x-rays whenever there is a whiplash fracture or whiplash fracture. That is nothing but the hyperextension of the neck at the level of C3. So keep that in mind. Next, here you can see herniations may also follow the degenerative changes in the annulus fibrosus and can be caused also by sudden compression of the nucleus pulposus. So it can happen because of annulus fibrosis, or it could be because of nucleus pulposus. Both the chances are there. And here is the herniation of the nucleus pulposus. And herniated lumbar disc usually involves the nerve root one number below. So if this is at the level of L1, then the affected nerve root would be the L2. Okay. So for example, here they have given herniation at the level of L4 will lead to the compression of the L5 root. So that is how. So L1 is compressed here and the root affected is L2. So keep this in mind and let's move to the next one. Abnormal curvatures of the spine you must have seen. Abnormal curvatures, you have the primary curvature and there is secondary curvature. The primary curvatures, you have the thoracic and you have the sacral. And secondary curvatures that is developed later on is the cervical region and also the lumbar region. Okay, so these two. So now here remember various, clinical aspects that we can relate with this. Here it is, the thoracic curvature that may occur in elderly people, that is known as osteoporosis. Sometimes multiple fractures can also result in such a posture, kyphosis. Okay, so disc degeneration also results in kyphosis. Fracture of the vertebral bodies also can result in kyphosis. So all this is because of disc degeneration, or it could also be because of the fracture of the body. That is kyphosis of the thoracic region. Then this one is lordosis. This is lordosis. This could be temporary or it could be, sometimes permanent. It could be because of spondylolisthesis. 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 And this one is scoliosis. It is because of lateral deviation of the or torsion that is caused by, it could also be because of a limp in the leg, that is poliomyelitis. So poliomyelitis can also cause the vertebral column to be curved, and that is because of the leg length discrepancy. Okay, so or it could also be because of the hip discrepancy. It could also be because of the damage to the nerve, that is superior gluteal nerve. So that can also result in the discrepancy in the height of the hip. So that you can test with the test, Trendelenburg test. Trendelenburg positive, you can say that the superior gluteal nerve is damaged or palsy, which supplies the two muscles, that is the gluteus medius and the maximus. Both are abductors of the hip. Okay, so that can also result in scoliosis. So such people also can have scoliosis. So keep that in mind. Next, let's go to the fractures of the upper limb. There are various fractures. So this particular slides are really, really important because there are questions also. So now here you can see the fracture of the humerus. One can happen near the neck surgical neck. There are two necks, anatomical neck and surgical neck. This is at the surgical neck. So which nerve is related? We have axillary nerve related to this. Then we have near the deltoid tuberosity, we have spiral groove. So this is also called the radial groove. Spiral groove has two things in it. One is the radial nerve plus profunda brachiae artery. Don't forget the profunda brachiae artery. Okay. It is not the brachial artery. It is the profunda brachiae artery. Whenever you hear profunda, it is the deeper branch of the existing artery. Then you have the fracture in the region just above the elbow joint, that is called supracondylar fracture. Supracondylar fracture can result in damage to the important, not just the radial nerve, it could be any other structure, because the supracondylar region is quite superficial because all the tendons come there and not much bulk of the muscle is present. So it could also damage the structures in the cubital fossa. Not just that, it could also damage the brachial artery itself. So here it will be brachial artery. Brachial artery and the ulnar nerve, medial epicondyle fracture. So medial epicondyle fracture, ulnar nerve, actually it is present in a small, tunnel. So the tunnel is not of much protection. So that can also damage the ulnar nerve, the fracture of medial epicondyle. So four things you should remember. One is the neck of the humerus, shaft of the humerus, the supracondylar fracture, and medial epicondylar fracture. So first one, axillary nerve, shaft, radial nerve. Then there is supracondylar, brachial artery. Then comes the medial epicondyle, ulnar nerve. So remember all these things in the humerus. Next one, fracture of the distal end of the radius. Fracture of the distal end of the radius. Here you know that it is most common fracture of the forearm. So it is again transverse fracture. You can see within just 2 centimeters of the radius. Distal 2 centimeters of the radius. So flexion of the fracture of radius. You know that inward fall is Smith fracture. I remember the I. Inward fracture is Smith. I would just circle this I. Then outward, that is called Fouche. Fall on the outstretched hand, that is Fouche, is O. So it is Colles fracture. Remember the difference between which one is dinner fork deformity. Just try to recall the dinner fork deformity. Dinner fork deformity is Colles fracture. Okay, dinner fork. So fall on the outstretched hand. Here what happens? From the forced extension of the hand. The forced extension of the hand usually as the result of trying to ease a fall by grabbing onto something. So you may just stretch your hand so much that you will be hurting the distal end of the radius. So that is what happens. That is, distal fragment will be displaced dorsally. It will be just displaced dorsally. And that results in an appearance as if, these fingers are those spokes of the fork and you have a bump here and that looks like a dinner fork. And often the ulnar styloid process is broken. So ulnar styloid process may also be broken at this point, but the distal end of the radius is what is considered and it is called Colles fracture. And here we have scaphoid fracture. Remember scaphoid fractures, the tenderness is seen in the anatomical snuff box. This is the first indication because the scaphoid bone is present or felt in the anatomical snuff box. What are the other structures in the anatomical snuff box? You can remember cephalic vein, you can remember. Okay, you can remember caul. Cephalic vein you can see, and then you can also see, not the caul, one second. Cephalic vein, then radial artery, and the styloid process of the radius. And you can also feel the scaphoid bone. So the fracture of the scaphoid bone happens when there is a push fracture or fall on the outstretched. This is the position. And what happens here is scaphoid fracture may not show on X-ray films for 2 to 3 weeks. It may not show at all, but a deep tenderness will be there in the anatomical snuff box. And it can also result in, later on, it can result in avascular necrosis, and then it may be a consequence of osteoporosis later in life because of the blood supply is interrupted. And this has the blood supply which is retrograde type. Unlike the other carpals which do have the normal blood supply, this is on the from the opposite direction. So that's why the proximal fragment may undergo, it is like a small peanut, it looks like that. Okay, this particular fragment, this is proximal, this is distal. The proximal fragment may undergo avascular necrosis because that's the first one to get the blood supply, proximal one. Okay, so remember this, the pain occurs primarily on the lateral side of the wrist. Okay, on the lateral side, that is where you have the anatomical snuff box, especially when you do the wrist extension, not when you do the flexion, whenever you do the extension, and also when you do the abduction of the wrist. Okay, abduction of the wrist. Next one, boxer's fracture. Here there is a important fracture, boxer's fracture. What is boxer's fracture? This affects boxing. Which muscle we use for boxing? Anybody has any idea? We use the serratus, right? We have the serratus anterior muscle, which is supplied by long thoracic nerve. So that is the muscle we use. And antagonist to this is not it is antagonist. Antagonist is the rhomboidus major and rhomboidus minor. You please remember, serratus anterior movement is considered to be protrusion, okay, protrusion of the scapula. And here we have the rhomboidus major and minor. What do? They do the retraction of the scapula. Retraction of the scapula is done by rhomboidus. Remember R, okay? Remember the R of rhomboidus. Remember the R of retraction. And this is also helped by trapezius, middle fibers. It has upper, middle, and the lower fibers. So middle fibers also help in retraction. But what we are talking here is the boxer's fracture. So boxing is done by all these muscles. What about the fracture? Where is it happening? It is happening on the fifth, here you can see. Okay, so here you can see neck of the metacarpal bones usually is what is fracture, but the usual one that is affected because of making a fist is the second, third of the metacarpals are seen in professional boxers. You can see the second and the third ones. Okay, here it could be. And fracture of fifth and fourth are also seen in unskilled fighters. So the professional ones and unskilled ones, usually the ones who simply get hurt, is fourth and fifth. The ones who are professionals, second and third. So where is it exactly? It is the metacarpal neck. Okay, remember, metacarpal necks. So in this one particularly, you can see this portion is fragmented. That is the fifth one. So how do you categorize this person? You can call him a unskilled professional. Okay, next one. What about rotator cuff muscles? How many are there? There are 5 rotator cuff muscles. There are 6 muscle, SITS. Okay, SITS. So like if you grab a humerus, you can place all these 3 fingers here. That is at the greater tubercle. And you can place another one here. That is for the lesser tubercle. This is subscapularis. You also have a bursa to this subscapularis. This also has a bursa. Usually this bursa can undergo bursitis, and that can also result in, because this is present this particular bursa is present within the cavity, within the joint cavity, then this can also result in osteoporosis later on. Sorry, not osteoporosis, osteoarthritis. Osteoarthritis of the shoulder joint. Okay, so that could be something that you can later on, expect if there is a inflammation of the subscapular bursa. So because that extends into the joint cavity, it has connection with the joint cavity, whereas the other bursae, you have supraspinatus bursae, you have subacromial bursa, you have deltoid bursa. All these other things do not communicate with the joint cavity, but only the subscapularis bursa communicates with the joint cavity. That's the reason. So now here you have all these muscles. Now you should remember subscapularis helps in what action? It helps in internal rotation. Whereas all other things help in external rotation of the scapula. Okay, sits, SITS muscles. So here you also have a groove. This you can remember it as the lady between two majors. Who are the majors? There is pectoralis major and teres major. In between that, you have latissimus dorsi. Latissimus dorsi. Okay. So latissimus dorsi is supplied by the dorsal scapular nerve. I'll write it here. Thoracodorsal nerve. Sorry. Thoracodorsal nerve. So that is the supply of latissimus dorsi. All right. And this one arises from the cord. This one arises from the cord. Whereas there is only one nerve, that important nerve, that is nerve to serratus anterior, that arises from the roots. Remember, it arises from the roots. So that is long thoracic nerve. Next one, abduction of the shoulder joint. Now you have in the upper limb, you have 0 to 15, you have 15 to 90, you have, and you can say you have 90 to 120. Okay, 90 to 120. So here you have to remember the supraspinatus muscle does the initial abduction. Initial abduction, if someone is not able to do, then that would be considered as painful arc syndrome. Painful arc syndrome. If there is a trouble, doing initial abduction, it is very difficult to make out initial abduction because the person would support from the other limb and he would lift the 0 to 15 degree. Okay, he would take support from the other limb. So it's very difficult to gauge that. That is supraspinatus muscle. And supraspinatus and infraspinatus are both supplied by the same nerve. That is suprascapular nerve. Suprascapular nerve. Okay. There is always a chance of damage to suprascapular nerve because it has a very unique, course, because it passes through a small notch, and whenever there is a bursitis or whenever there is a callus formation or whenever there is a whenever there is a bony spur formation, always this nerve can easily get compressed, suprascapular nerve. For various reasons, it can get compressed, and that can result in the condition called painful arc syndrome that involves supraspinatus muscle exclusively. Next, you have the deltoid muscle, which is supplied by axillary nerve, and that does the up to 90 degree. Up to 90 degree is deltoid. And just by looking at the contour of the shoulder joint, here is a contour, you can easily make out whether the axillary nerve is damaged or not. And also axillary supplies through its superficial branch. The cutaneous branch is called superficial branch, and it is supplying the regimental badge area, this one, the lower portion of the deltoid region. and that particular region is supplied by the axillary cutaneous branch. Okay, so whenever there is a loss of sensation in this area, that can also indicate that axillary nerve is damaged. It can usually happen because of the fracture of the humerus near the neck, or it could be because of inferior dislocation of the shoulder joint. Okay, next one is this is overhead abduction. Overhead abduction is done by serratus anterior muscle. And you know that the trapezius also helps in overhead abduction. So you have trapezius muscle, the upper fibers. Now, trapezius is very interesting muscle because it has a very big attachment from the external occipital protuberance up to T12 it has. And see where it goes. It goes to the acromion process. It goes to this region. Okay. So when it has got such a big portion, it has upper fibers. It has the, middle fibers. This is the upper fibers. It has middle fibers and it also lower fibers. So lower fibers, you can see middle fibers help in retraction. This one helps in elevation of the scapula. This one helps in depression of the scapula. They all work on scapula. Because why? Because they're attached to the handle of the scapula. That is the spine of the scapula. All right, next one. Subacromial bursitis. Subacromial bursitis is very important. Why? Here you can see subacromial bursitis because sometimes I told you the tendon of the supraspinatus can get calcified. See here, the bursa is filled with fluid and it is inflamed, and it is also causing a lot of pressure to the muscle that is beneath it. There is an inflamed tendon and it is also pressing on the bursa, and you can see the bursa itself is inflamed, and that results in painful arc of abduction. So abduction, that is initial abduction 0 to 15, has become very painful. That's called painful arc syndrome, involving subacromial bursitis and pressing on the supraspinatus tendon. Next, see the golfer's elbow, and we have tennis elbow. Okay, so golfer's elbow, you please remember, it is medial side, and even the cricketers, they use the same style, right? Cricketers and the golfers, they have the medial side. This is medial, and this is lateral epicondylitis. Medial epicondylitis, lateral epicondylitis. These are all extensors. These are all flexors. Okay, flexors of what? Flexors of the forearm. So here you have medial epicondyle, inflammation of all those tendons on the medial epicondyle. Which tendons? The flexors you have, including pronator teres. Pronator teres. Okay. Remember, in the extensors, you also have supinators. Supinator belongs to the extensor group. So here, a repeated forceful flexion and extension of the wrist, it results in strain attachment of common extensor tendons. Now here, pain is felt where it is felt. It is felt over the lateral epicondylitis and lateral epicondyle, and radiates down the posterior aspect of the forearm. So the pain is on the lateral epicondyle and radiates down the posterior aspect of the forearm. And it is often, presented as opening a door or lifting a glass. So whenever you try to do opening the door or you're trying to lift something heavy, then you can feel the pain. Next one, what the anastomosis around the scapula? We have anastomosis around the scapula. We have anastomosis around the elbow. And we also have anastomosis in the lower limb, trochanteric anastomosis that is called. So here there is always an important vessel that connects. So what are the two things that connect to form the anastomosis? One is the subclavian or axillary. So this is the one. Okay, it anastomoses with the branches of the thyrocervical trunk and subscapular artery. All right, so blockage of subclavian or axillary artery, you can always bypass it because by anastomosis between the branches of thyrocervical and subscapular artery. All right, so that is something that you can do. Not this one, subscapular. Where is our subscapular? There is, it is. Subscapular artery. So branches of this, you can see in the dotted line here, the branches of this and thyrocervical trunk can be actually, you can use this as a detour or an alternative whenever there is a blockage in the subclavian or axillary. So whenever there is a blockage in this, you can use the thyrocervical trunk to anastomose with the branches of subscapular artery. So now here, transverse cervical, it takes part in the anastomosis, suprascapular takes part, the subscapular will take part, and also circumflex scapular will take place. Next one, cubital fossa. Now coming to the cubital fossa, now you tell me what are the structures present within the fossa. Now here you have to remember medial to lateral, what structures are there, or lateral to medial. One direction you have to learn. Always we go lateral to medial. Okay. So we have lateral to medial, tendon, artery. Okay. Now, tendon, artery, nerve. You can remember this as STAN. So we have the tendon, biceps tendon, then artery is the brachial artery, then we have the median nerve. Okay, median nerve. So here you can see the aponeurosis of biceps, that is called bicipital aponeurosis. You can see that it extends medially and the tendon goes laterally. And subcutaneous structures from lateral medial also you can see. You can see the cephalic vein connecting with the basilic, you can see. Then in between the connector vein, the medial cubital vein also you can see. Where is cephalic, on which side? It is on the lateral side. Remember, is the basilic is near the side of your body, your side or body side. Okay. The cephalic, remember the C, it pierces clavipectoral fascia. It pierces. So remember the C for clavipectoral fascia. It pierces clavipectoral fascia, C. Okay. And it is also seen in the anatomical snuff box. So these are the two specialities of the cephalic vein. And it is also one of the veins for central venous catheter. Central venous catheter. So C has got a lot of importance here. That is cephalic vein. Okay. Now sites of venipuncture is usually done on the median cubital vein. Why? It is because of two reasons. One is it is because it overlies the bicipital aponeurosis, and so deep structures are protected. All right. So there is no much damage to the other deeper structures because you have a shield between them. That is the bicipital aponeurosis. So aram se you can do the venipuncture. The other one is it is not accompanied by any nerve. So there is no question of damaging any nerve beside it. So there is no nerves around it. So best is to take the blood sample using venipuncture method to do on the median cubital vein only. That is the choice. Next one, carpal tunnel syndrome. Let's look at the carpal tunnel syndrome and see what we have here. Carpal tunnel syndrome, it results from a lesion that reduces the size of, it results from a lesion that reduces the size of the carpal tunnel. Okay, so now here you can see that there is a connection between the medial and the lateral sides of the carpals. So which are the ones which are on the medial side, which are the ones which are on the lateral side? We have scaphoid, we have the triquetrum, All right, here we have the hamate and the pisiform. These are the ones. So the connection between them is known as carpal tunnel. Okay. So there are structures that pass underneath. There are structures that go over above from the carpal tunnel. So here it reduces the carpal tunnel and there is fluid retention and there could be infection and there could also be dislocation of the lunate bone. So remember, whenever there is a carpal tunnel, there is always a chance of dislocation of the carpals. So these carpals, one of the important bones that could get dislocated from its, setup is the lunate bone. All right. Next, the median nerve, which is most sensitive nerve in the carpal tunnel, that can also be affected because it goes underneath. So that is another point. Then other clinical manifestations you can list are the pins and needles sensation on the medial 3.5 fingers, okay, including the palm area. The palm sensation would be just gone. Lateral 3.5 digits, pins and needles sensation. And that is because of superficial palmar cutaneous branch, it passes superficial to the carpal tunnel. So that is why this is not affected. Palm sensation is not affected, only the fingers, pins and needles. It is not the palm. Why? Because the superficial palmar cutaneous goes above and this region is unaffected. Okay. So this region is unaffected. The fingers are definitely going to be anesthetized. And there is ape hand deformity. Ape hand deformity is absence of opposition. This cannot be done, opposition. And also the thenar muscles will have wasting of the muscles and it could be flat, just like ape hand. So remember, what is retained is sensation on palm. Why? Because the superficial palmar cutaneous branch goes above the tunnel and it is unaffected. That's why this is retained. So sensation on the palm is retained. Affected is which one? Affected is the fingers. That is lateral 3.5 fingers. Okay, that is sensory is lost. Next one, let's see what we have here. We have proximal and distal interphalangeal joints. Now we have proximal and distal interphalangeal joints. You can see all this. So this is the proximal joint and this is the distal one. You can see the bend here. You can see the bend here. All right. So who bends all these? These are all done by the interphalangeal joint. What kind of joints are they? They are all hinge joints. Who does the extension? Extension of interphalangeal IP is done by lumbricals. Okay, these are all done by lumbricals, extension. And flexion, what you can see here, is done by those flexors of the forearm. Those flexors of the forearm, respective forearm. So here it is the index finger. So it is flexor indicis. Does the flexion. Okay. So that is done by flexors and extension is done by lumbricals. Lumbricals will do extension at IP and they do flexion at MCP. Just like, you do this snake face like this. Or you can just, cup your hands. When you cup your hands, you have the flexion at MCP and you have extension at the IP. So that is the action of lumbrical. And lumbrical is very important set of 4 muscles. Next, you have lesion of ulnar nerve. Here, ulnar nerve can get damaged because of fall or it could also be because of birth injury. So here you can see the lower trunk is affected, right? affected. That is because of pulling off the head during difficult delivery, pulling off the head. So that can result in lower trunk affected. Remember the Klumpke monkey. This stanza you can remember. Klumpke monkey was hanging from lower trunk of tree. If you remember this, what is Klumpke? Klumpke is palsy, you can remember. And hanging from lower trunk of tree. So that is the lower trunk affected. So there is lesion of ulnar nerve, upper brachial palsy, injury of upper roots and trunks is usually the Erb's palsy. Okay, upper one is Erb's palsy. Then lower one is Klumpke's palsy. All right, so this is the upper brachial palsy. This is the Erb's palsy. You can also call this as the waiter's stiff hand. And the nerves affected are axillary, suprascapular, and musculocutaneous. The one which is spared is ulnar. Ulnar is spared. So here you can see he can definitely move. All this is fine. But this is not fine. This is not fine. All this is not fine. You can see it is pronated. It is adducted, medially rotated, and also this is extended. And you can also see it is medially rotated and it is adducted, right? There is also loss of sensation on the lateral aspect of the upper limb because of the musculocutaneous nerve and axillary nerve being affected. Axillary nerve supplies this region and that is the affected one. The main thing that is affected is deltoid. So deltoid does abduction and that is what is not happening here. Next, you have seen lower brachial palsy, Klumpke palsy. See here, you can just remember the, the person hanging from the trunk. So here you can see there is extended. This portion is completely, stretched. This is what happens. When the head is pulled, it is Erb's palsy. Okay. Whenever the limb is pulled, remember L for limb, L for lower, and it is Klumpke. And that is also L. Klumpke L, limb L, lower L. All the three L's you remember, all the three L's. Okay. So this affects which root? T8, T1, because T1 is also involved with Horner's syndrome. Remember Horner's syndrome, that is got something to do with the sympathetic trunk, right? So T1 root is involved in that also. So Klumpke and Horner's syndrome you can connect. Next, this is how it looks. The lower brachial palsy. All these intrinsic muscles which are supplied by the ulnar nerve are affected. Okay. Now combination lesions, you can see some of the claw hand you may see. You may see also ape hand you can see. And there is also loss of sensation on the medial side of the fingers. That is medial side. 1.5 fingers, 1.5 fingers because of the ulnar nerve defect. Okay. So it may also include Horner's syndrome. Very, very important. Don't forget the Horner's syndrome to associate with the Klumpke's palsy. Next one. Injury to musculocutaneous. You remember musculocutaneous? First it is muscle, supplying the muscle. Later on it becomes cutaneous. Where does it go? It goes to the lateral side of forearm. And one more thing is it pierces the coracobrachialis muscle. Okay, it pierces the coracobrachialis muscle. It's a very important nerve supplying all the flexors in the arm. It supplies all the flexors in the arm. And also one, to some extent, whenever there is an injury to musculocutaneous, the person may also show some difficulty in supination. And you might be wondering why the person is having difficulty in supination, because the biceps brachii also does supination. It is the accessory muscle for supination. That's why when this is affected, obviously the action is also affected to some extent. That's why person may show affected supination along with the affected flexion of the elbow. Okay. And also no sensation on the lateral side of the forearm. It is like anesthesia over the lateral part of the forearm. Next, the cutaneous innervation. When you see here, you can see the radial cutaneous supply. The ulnar side is 1.5 here. This is the 3.5. But you remember the tips of the fingers here, it is median. Okay, it is median. It is not radial. It is median. On the back side also, you can see it is median. It is not radial. And of course, here you have median. But here you see near the anatomical snuff box, it is radial. So how do you define this? And here you should remember this near the anatomical snuff box. Whenever there is an injury near the anatomical snuff box, it's not just the scaphoid that is, fractured. The person also may show loss of sweat and sensation. Okay? Because of injury to radial nerve, because radial nerve also is the sensory to the anatomical snuff box. It is sensory. So when it is a sensory, it also supplies the sweat glands there. So there is loss of sweat and also loss of sensation near the anatomical snuff box. Very, very important. When you read the question, see properly, have they written loss of sensation, loss of sweat in the anatomical snuff box, then immediately your mind should go to radial nerve, because that is what supplies the anatomical snuff box sensory. See here, this is the sensory. And rest all the things, even though it is 3.5 fingers median, only near the anatomical snuff box, very difficult to put it in words. If you look at the diagrams, it's always easy. So keep this diagram like a picture in your head until the exams are over. Okay, it's always important you look at the pictures and keep the picture in your mind, because words, it is very difficult to describe with words what actually is the sensory. Okay, so how do you define this? I can say 1.5 fingers and I can say 3.5 fingers, except the first interphalangeal joints are not supplied by the radial and they're all supplied by median. But on the palmar side, you have anatomical snuff box that is supplied by radial, not the median. Instead of so many words, it's better to look at a picture, right? Next, let's see. Richa, yeah, sympathetic and parasympathetic. Yes, best idea, Richa. I should make sympathetic and parasympathetic. I'll tell you the sympathetic and parasympathetic. Remember, what are the actions you do with the parasympathetic? You remember simply just for the exam goers, SSLUDD. Okay. It is sexual activity, salivation, lacrimation, urination, defecation, and the digestion. All these are the activities. Okay. All these are parasympathetic activities. I will definitely do that. I'll take your suggestion. Next one, avascular necrosis of femoral head. Femoral head avascular necrosis. First of all, what supplies the femoral head? It is supplied by the medial circumflex femoral arteries. Okay, through its retinacular branches. And that is the transcervical fracture is what disturbs the blood supply to the head via the retinacular arteries. Retinacular arteries travel from here to there in that direction. Okay. So when they don't travel, that is what results in avascular necrosis. So here there is a damage and it is all because of the branches going from the medial circumflex artery via the retinacular branches. So remember the medial circumflex artery and the branches are all these retinacular. There is one artery still supplying here. What is this one? That is the branch from the obturator artery. Okay. So this is inadequate. This is not sufficient. This is going to just drag the process. It is inadequate. This branch is from obturator artery, but that is which branch? It is from the posterior branch of obturator artery. Is this sufficient? Do you think one small twig, is it sufficient? It is not sufficient. Okay, so anyway, avascular necrosis will happen, but it will only lengthen the period of damage. Next one here, you can see the knee joint injury. So unhappy triad, you remember the unhappy triad. What are those unhappy triads? There are three things. One is the tibial collateral ligament. There is medial menisci and anterior cruciate ligament. You remember MMA, unhappy triad. Don't say it as middle meningeal artery. It is nothing to do with the middle meningeal artery. Okay. We are talking about knee here. Don't get confused. It is MMA, that is the medial collateral ligament. Then there is M, medial menisci and anterior cruciate ligament. Very important is to remember anterior cruciate ligament. Okay. In the knee injuries. What this game is, this is like rugby or foosball or foosball it is called. Next you have fibular collateral ligament. So here it is very simple because this ligament is got no connection with the menisci. So it does not blend with the joint capsule nor it attaches to lateral menisci. So it is pretty safe. This is one is safest. Okay, so it only helps in limitation of the extension and adduction of the leg. That's all its job is. So it is usually not involved in any kind of applied aspect. So rupture of the cruciate ligament, the anterior and posterior cruciate ligament, anterior draw sign, posterior draw sign, you have to remember anterior draw sign and posterior draw sign, ACL. All right, so here we have some of the things that I need to tell you is you are watching the Unacademy, you are watching my class. I'm Dr. Rohini and you are watching some of the important grand recall, okay? So we did some of the recall. I hope it was helpful and please join the Telegram channel in case you want to download any last minute stuff. And if there are any new students watching, please do join Let's Crack NEET PG. And I also have this nice group where we discuss many things regarding subscription, the topics that you haven't understood and you want to just ask any clarifications, Anatomy by Dr. Rohini. So you can join this and we can take this further with more discussions. So here are some dedications from my dear students in the form of hats. They have received a lot of appreciation and they have passed on those hats to their educators. And this is the Telegram channel. And here is some, courses that you can definitely look at, iconic and plus courses. And we have every Wednesday special classes. Please do join our special classes by downloading the app, that is Learners app. Okay, you can download it from the Play Store or the App Store. You can download it and I'll tell you the steps to download. You join my Telegram. I will tell you everything in detail. There is also special class features that you can see. It is much more better than any other, YouTube classes. So here are the steps to get into those subscriptions. Please do follow. When you want to subscribe, please use the code ROHINI 10. So when you use the code, you also get 10% discount. Isn't that nice? So here is how to install the app. And we also have FMG, BAT, and Target Next 2022-2023, where I'm there on 22nd September. So please block your date for this. This is on the Target Next 2023. Okay, watch me there live. And we also have some students, we are very proud of them. That is FMG scores. You can see it's like 210, 227, 237. What marks? Wow. So this is all thanks to Unacademy. And Bugs Bounty is a feature where you feel anything is inappropriate, you can report. And you want to subscribe, like, and share, please do go ahead and do that. And you can also download the PDF format when you have joined any special classes. So for that, you need the app. For that, you need the unlock code. The unlock code is, again, let me just remind you, it is Rohini 10. Okay. This is also called the, unlock code or the referral code. And here are some of the subscriptions you can go for. You can see the batches have started on it. There are many, many things happening at the same time. Just visit the website and see what all you can get into. And there is also 1 month package you can look at. And there are so many questions on QBank series. If you haven't taken, please go through. It is very, very important and really informative. And we also have medical PG to boost. We have 24 plus 4, 12 plus 2. All this you can keep in mind. All those who are new ones who have joined, you can definitely be, boosting your medical PG preparation with such unlimited offers. So here you have NEET PG subscription plus an iconic EMI option also is present. So you can go with this with minimum of 6 months subscription, and please use the code ROHINI 10. I'm writing it again for the nth time. So use the code. The code is very important here. And this is all we have. And big thanks and all the best to all my dear students. And I hope you will all score really, really well and we'll pray for you.